want to move on to the unresectable liver dominant. Were either of you all investigators in the SIRFLOX study? I wasn't, but I know the data pretty well. I mean, it was chemotherapy on one arm, continuous sort of standard chemo, with the other arm being chemo with intrahepatic therapy, a single injection of radio-impregnated beads, and so not what we're doing now, right? So we're doing now multiple injections and things like that. So it was a single injection. And the definition of liver dominant, you could have extrahepatic disease, but it had to be small, basically. And the findings, we're going to see presented, actually showed at least a liver progression-free survival of a big chunk of change, as we say, from 12 months to 20 months. Talk a little bit about what you think that does for us. As we talked about surgery. Where's the role? How's this going to affect practice going forward?
Yeah, well, I think the data we'll see here is that the overall progression-free survival, which was the primary endpoint, was not improved, but the liver-specific progression-free survival was markedly improved. So the question is, what does it mean? Is it the indolent, asymptomatic, harmless pulmonary metastasis which occurs and limits the progression-free survival interval, and which means clinically nothing? Or does it mean that the patient, when we block the liver and you control the liver, let's say entirely with the yttrium-90 radioembolization, then we'll have a, let's say, spreading on liver lung metastases, on a massive, let's say, increase in lung metastases. This would be clinically have different meanings. And for this analysis, it's unfortunately too early.
Yes, too early. And there's other trials coming. Yeah.
The implication on overall survival. I'm relatively optimistic that this will translate into a larger overall survival benefit than in a progression-free survival benefit. So PFS is not a relevant endpoint.
But there is again a complexity, because this approach could not be done easily in patients that are followed by community doctors or by small-sized or medium-sized community hospitals. And so again, we go to the complexity of treatment to big cancer centers, because, and this could be also a reason why it's not very easily applicable to the unfortunately common metastatic colorectal cancer patient that has unresectable metastasis, even if it's predominant the disease in the liver. So I think this is again to a shift to collect all patients in big cancer centers. I don't think that this could be easily done in most countries, especially in the US, maybe.
Yeah, but not necessarily. But I would say, for me, SIRFLOX is strengthening the concept that we should start to treat patients with the best systemic treatment, and then we have a kind of response, we should use the best ablative strategy. And this, for me, encourages the use of yttrium-90 as a kind of consolidating maneuver for patients with a widespread but liver-limited metastatic disease.
If it's your liver, you going to do it?
This is a very good question, because usually when you think as a patient,
it helps.
It helps you because you don't think about percentage of difference in efficacy, in terms of hazard ratio, in terms of major toxicity. You hope that even if there is 1% chance, you will be that 1% person. And that's why, for example, I remember several years ago, maybe 20 years ago, there was a questionnaire to metastatic cancer patients treated with chemotherapy, asking them which was the risking toxicity and the marginal benefit they were going to. And doctors will answer with a much lower threshold than patients. So if you say to a patient, you have 10% possibilities that this will help you, the patient will think about not the 90%, but the 10% people that respond. So this is another major responsibility we have when we discuss with our patients in a truly informative way what are the therapeutic options.
The one thing I'm a little nervous about, although it's very exciting data, is I don't think we have a lot of long-term, downstream liver toxicities, hypersplenism. So do you have a patient with a platelet count of 50,000, and now you can't do anything more?
I would say the time point for this maneuver in the SIRFLOX trial is by far too early. We don't know whether the patient is under control from the systemic treatment. I would like to see this from patient before and then use this as a kind of consolidating treatment rather than the early stage of the career. Yeah, because the patient has to undergo treatment in 3-4 treatment lines, has to preserve the liver for years.
So